Hello, good evening everyone. I'm Chris Holsinger, and one of the head and neck surgeons here. It's a pleasure to see all of you out. Thanks for missing dinner, or hopefully just being a little late for dinner with your families. We have some special guests here. We have some folks from Intuitive that showed up, and most importantly, we have our two speech language pathologists here. Thanks guys for coming. I'm sure there's several other of you, several other members of the audience that I probably am not acknowledging right now, but last week we heard a talk by Dr. Weber on head and neck, and this week I'm going to continue in that vein and talk a little bit about robotic head and neck surgery, and give an update on the randomized prospective clinical trial ECOG 3311. Talk a little bit about next generation technology, which some of you in the room have been working with me on to develop. And talk very briefly about the cost and value of doing robotics, because I think the economic value of this and the patient value of this. This is a nice talk, but it's not going to go anywhere. We really have to think about the dollars and cents these days. So first of all, I want to acknowledge all of my different division members. It's been a true pleasure to be here for 2 years, and it's really great. It's a great group, and it's just an incredible honor to sort of watch this program grow. To watch Dr. Devi shave his beard and then grow it back out. To watch Dr. Sajani put on a tie, looking good. And Heather Starmer joining us. We really appreciate you being here. And Ann, thanks for your help too. Lisa, I think, had to head home tonight for a back to school event, and I think Evan is at an SHC retreat, so this is their regards. That's really important. I'm going to talk about a lot of technology. As you know, I may or may not be addicted to technology, but I have no commercial relationship to Intuitive Surgical, unfortunately. Greg Weinstein always talks about, what if I bought 100 shares of stock in Intuitive in 2006? But unfortunately, neither one of us did that. And but I'm making light. Actually, I have no commercial or financial relationships of any kind to any of the companies discussed here tonight. And that's very, very important. So, head and neck cancer, very brief review before I dive into the discussion of why robotics is important. This is no longer an orphan disease. Every year in January, the American Cancer Society prints the latest data. And actually, head and neck cancer is the #8 most common cancer among men in the United States this year. Interestingly, thyroid is #5 for women. So really, ENT and head and neck surgeons are really faced with a very important public health problem that was very different than when I was a medical student, when I was sitting out there, like Visual and Bo and others out there. These were rare diseases, and now everyone will see these cancers. And that's why I think it's important to review some of these data and have a handle, even in the world of comprehensive or general ENT, about what's your take on how we're going to treat these, and what is the role of surgery, and that's what I hope to talk about a little bit later. But I want to cover some basic ground first here. So here are the actual numbers. So 60,000 cases if you combine larynx and oral cavity and pharynx. Very frustrating because oral cavity and pharynx are lumped together, so we really don't know how many incident cases of oropharynx cancer are, because oral tongue is very hard to distinguish in the database from oropharynx. But nonetheless, a significant rise, which many of you are well aware is due to the association and surprise association with HPV, human papillomavirus, and the relationship between increasing numbers of oral sexual partners. Based on this new finding, we've seen a 225% increased incidence using a small subset of the SEER database. Neil Chaturvedi and others at Hopkins and the NCI actually showed this curve recently, and the numbers. Mara Gillison, you may know, was here. Mara helped and was really instrumental in sort of unraveling this relationship between HPV and oropharynx cancer. She said, if you, sorry, I'm being recorded for the grand round. She said these curves are now really spiking up quite dramatically now. I mean, the rate of rise is probably going to increase over the next 10 years. Therefore, the issues we talk about tonight I think are going to be even more pressing, because we're going to see more and more patients with this disease. So the good news is that HPV positive patients do so much better than HPV negative patients. As many of you know, HPV negative head and neck cancers, whether that's in the oropharynx, larynx, and oral cavity, are associated with heavy tobacco use, smoking, or oral, as well as heavy ethanol use. And I want to direct your attention to a really important study, RTOG 0129. It was published in the New England Journal of Medicine in 2010, and it is a post-hoc analysis of a really interesting experience. And I guess I'm going to talk a little bit about the data, but I want to draw attention to the folks in the audience who are thinking about careers in science in this field, that it's one of the most important take-home messages about this slide is not what I'm going to present, although the data is amazing. The take-home message is that do the study. Don't keep talking about it. Don't speculate. Don't wait for a perfect study. Do a study, right? Because 0129, which no one even knows about, was a study that compared altered fractionation, right, doing BID dosing plus cisplatin to regular, once a day standard fractionation with cisplatin. There was no difference in that outcome, right? 720 patients. Those two groups, the experimental arm and the control arm, showed no difference in survival. But this study included 720 patients, and from that, they had a huge repository of patient data as well as many samples. And in fact, they had over 300 samples of oropharyngeal cancer patients. So that when Mara Gillison approached Kian Ang, who was the chair, and he's the first author of this paper, to ask the question, wow, we're seeing this huge rise of oropharynx cancer, and you've got a prospective study, we could actually look at outcomes in a really novel way. Kian and the RTOG could really change practice because they had done the study and they had the samples. And otolaryngologists and head and neck surgeons, we need to be part of this. We need to be at the table, we need to be doing those trials, we have access to the samples so that we can make these kinds of observations. But nonetheless, I'll get off the soapbox now. The point is, get involved, learn about clinical research, and get out on the playing field. So in this study, which is again a post-hoc analysis of a very large data set, they compared the outcomes of HPV positive patients versus HPV negative patients. Overall survival is substantially different between these groups. Really a 25% difference. And keep in mind, I'm not going to go into much more detail, every patient in this trial, stage 3 and 4. This includes N3 patients, it includes T4 patients. These are the worst of the worst. And maybe not every T4 was alive at 3 years, but 82% of that group, when they're HPV positive, are doing quite well. Why is that? Significantly reduced rates of local regional relapse, right? So the tumor is better controlled in the tonsil, the tongue base, and the rest of the oropharynx. The rate of relapse in HPV positive patients only 14% versus 35% in the HPV negative group. Distant disease is exactly the same. So you think, wow, why is Holsinger here talking about robotic surgery? I mean, we just chemoradiate everyone and we're all taken care of. Well, I think let's think about that. I mean, it's really our standard approach. I mean, multidisciplinary care really is founded on this. Ironically, it doesn't really include minimally invasive surgery or really open surgery because open surgery provides such poor functional outcomes for the oropharynx. And while we believe that radiation is what we did believe, especially just even as short as 10 years ago, that radiation was the way to start out for all of these patients, even the early stage disease, what we saw is a trend of and a gradual shift toward treatment intensification. Through altered fractionation, like we studied in 0129, that actually was first documented in a study in 1995. Hyperfractionation, which is actually BID fractionation for almost the entire treatment course. Concurrent chemoradiation with cisplatin was pioneered actually in France with the Gitec group in 1999. And you see the survival curves on your right that showed a significant difference in overall survival as well as local regional control in this study from 1999. So radiation works, it should be the foundation of what we treat, but we keep tweaking it to get better results. And ironically, we keep tweaking that fundamental treatment approach, but not include surgery. Mitch McTay, I think, sort of drew attention to the fact that we sort of reached a zenith, if you will, in optimizing how all these different modalities work together. And this paper, which was published in the JCO in 2008, looked prospectively at this approach of concurrent chemoradiation, which after Calais and Forestier and some of the other data, by the mid part of the first decade, was the standard approach. There just wasn't a thought. I mean, there are discussions out in tumor boards, well, that's a low volume T2, N0, or N1, but it's stage 3 cancer, and Calais showed the better outcome, so I better radiate that person with chemotherapy. If I withhold the chemotherapy, am I depriving them a chance of 10% improvement of survival? But we were just forging on with this until folks like Mitch started looking critically at this experience. And what he did in this study, which is a pooled analysis of previous RTOG trials, 9111, 9703, and 9914. 9111 is the big VA, the follow-up VA larynx trial. These are 2 other trials. 13% of patients treated on RTOG trials out more than 2 years from treatment. So this is not minimal acute toxicity after treatment. But 2 years after treatment, these patients can't swallow. And Ann and Heather can tell you more about this. Significant late pharyngeal and laryngeal toxicity. A substantial portion of patients actually died from treatment long term due to renal failure and aspiration. But overall, 43% of patients who are treated with upfront concurrent chemoradiation, even in the best of hands in RTOG, actually had some sort of long-term toxicity. So remember that number, 43%. That's a huge number. But it's a new era, and are we going to keep treating patients this way? Are we going to keep treating kind of the new era, which you find out as much about in JCO, Chicago, New York Post, with the high-profile Michael Douglas case, with the ideas that were pioneered in the Marlboro Man generation, right? Let's just throw everything at these folks. Well, that's not really appropriate anymore, because one of the key differences between the HPV-positive population, which is now filling our clinics, and the HPV-negative population, is the fact that these patients are much younger. The HPV-positive population tend to be, on average, a decade younger than the HPV-negative group. It depends on what study you cite, but I just threw up a couple of New England Journal papers to kind of prove the point. The VA study, the average age was 62 years, smoking-induced HPV-negative tumors. Recent studies, Posner and his TPS study, the average age had already dropped to 56. Mark Gillison and Gypsember D'Souza, who really, again, unraveled this connection between oral sexual practices and oropharynx cancer, showed that 85% of their population was under the age of 65. 85% of big New England Journal studies now are in patients in their 50s, which is pretty shocking. One thing we noticed at Anderson, and I was very lucky to sort of be growing up and listening to Kian and listening to everyone say, we need to really try concurrent. Maybe induction will work. Hadn't yet thought about surgery. We started to see very severe late side effects. And in particular, we saw those side effects in the young patients. Now, I will disclose my age here. I'm 48 years old today. And so, young therefore means someone in the 50s. And so we just took the age of 55 as being young. And we said, patients who were 55 and younger in MD Anderson, we had good long-term follow-up on. How are they doing? And in this study, we showed for those patients who were treated, some of them with just single modality radiation therapy, we saw a very high rate, 82% of silent aspiration in those patients. A remarkable finding. And this study originated by this one patient whom I saw. He was a chef from New Orleans who had an unknown primary. They found it in the tonsil. He was chemoradiated in 1995. This is how he shows up to me. I'm kind of junior faculty in 2003, seeing a bilateral hypoglossal nerve paralysis. I spent, several thousands of dollars trying to figure out why he couldn't move his tongue, and it was just late effects from radiation. So I think as we saw this changing epidemiology, we're moving perhaps away from our standard approach. And it's not because chemoradiation is bad, it's not effective. It's because of toxicity. And I think as surgeons, it really behooves us to keep making that point, that we're in the future really going to rationally de-escalate and de-intensify our treatment. And one of the ways to do that, that's a really shocking slide, but one of the ways to do that is by moving away from old surgical concepts, embracing new technologies like robotics, like laser technology, and moving away from large radical open incisions, moving toward endoscopic surgery. I think it's really important to actually call this what it is, which is transoral endoscopic head and neck surgery, rather than always calling everything TORS. Or, you know, if you're Mike Heaney, you're a laser jockey, and so he's a laser guy, and Greg Weinstein is a robot. You know, what we're really doing is we're surgeons who are using a minimally invasive approach, using endoscopes and advanced visualization technologies to operate through the mouth. That's really all it is. And I think we need to be talking about what we're doing in this arena, independent of the companies that make the technology, and independent, in fact, from the technologies themselves. And that way, as Intuitive comes up with their next generation, and this company X that, you know, Shopy's going to work on, you know, yeah, we're gonna be separate from all that, and we're actually developing a body of literature that's about the anatomy and the approach. And so this actually was published, I guess, 2 days ago, and so it makes this very point that we're we're at the start of a new era where we're focusing really on transoral endoscopic approaches, not the technologies that facilitate. So, of course, many of you know, I talked about this a couple years ago. You've had other speakers before who've spoken about robotics. It was really, no one did more to promote robotics and advance the ideas than Greg, though. Greg Weinstein at Penn. And as he started to publish papers beginning in 2005 and then culminating in this multi-center study that was published in 2012, we looked at 177 patients and showed the value of operating on these patients in terms of having very low positive margin rates in, I would say, as best you can get, a prospective multi-center trial, and very low complication rates with experienced surgeons who did a lot of transoral surgery, with the laser or without. Low rates of trachs, low rates of PEG tubes. This seemed to work, and then based on that data, the FDA actually approved davinci, the only robotic device that's available out there right now, for T1 and T2 cancers. And down in Houston, you know, I just showed you a study of 720 patients that were treated to study altered fractionation, right? And there was this amazing scientific observation made about HPV. All Randy Weber and Kian Eng said to me is, show me the data. You've got to be kidding me. You want me to change practice based on 177 patients? That's not going to happen. And so naturally, I think there were some zealots who were pushing forward, and I may or may not have been one of them. I like to think of myself as a balanced zealot for transoral endoscopic surgery. But very recently, in fact in April, Ryan Lee presented some data, our now Oregonian colleague. He presented some data at CAUSA that showed the largest experience, and I'm pleased to announce actually that this study will be published later this month in the JAMA OHS journal. And this really shows for the first time across many different centers, frankly a lot of different levels of expertise, the potential robust nature of this fundamental surgical approach. Or it shows that HPV positive disease is a lot easier to treat than HPV negative disease, and a transoral approach is therefore amenable and appropriate. We actually don't know if TORS is that good or if the biology is that more amenable to these minimally invasive approaches. But we showed in this study, which I think some of you have seen some of these slides before, but really excellent 2-year local regional control, over 90%, very good disease-specific and overall survival, and very low rates of local and regional recurrence, as you see there. But that wasn't enough. We started this in 2011. It took us forever to get the data together. It took us forever to standardize the data and to mature it. And I have to thank Krista, who's, there you are. Thanks for helping us out, cleaning up some very dirty data. Very dirty data. And Ryan for writing up, and for Dr. Damrose, I'm so disappointed he's not here. I can't embarrass him with that photo. But Ed contributed several, I think maybe 8 patients to the study. So it's a true multi-center effort. But that's not going to be enough. And Drew Ridge, who's head and neck surgeon, general surgeon at Fox Chase, and David Adelstein, who's a renowned medical oncologist at the Cleveland Clinic, kind of started to see where this is heading, right? There's going to be a lot of backstabbing and fighting, and I know this and you know that. They said, look, let's stop arguing and do a study. And they wrote an R13 grant, which anyone can do, funds scientific meetings to gather people from around the country and world to talk about pressing clinical problems. We all met outside of DC to talk about this new approach, transoral resection. The proceedings of this study are shown here, and you can read about them in head and neck. But out of that consensus meeting came this, I think, very important trial. And I've been very lucky to be involved in the initial inception of this, and then, as you'll see a little bit later, in its implementation, especially surgeon credentialing and some of the initial quality assessment and monitoring that's being done. So I just want to review very briefly what this trial is, and I'm going to quickly go through credentialing and show you a little bit about how we've been able to herd my various colleagues in line, both in terms of credentialing and the way we're actually doing these surgeries in a consistent manner across institutions. It's an unprecedented effort in head and neck surgery, and I'm really excited to be part of it, and I think it'll make a big difference for our patients. But nonetheless, here's the study. So here are the eligibility criteria over here on the far left. Just like the patients I showed you in 0129, they're all stage 3 and 4 patients. They couldn't be more different, right? No T3, no T4, no N2C, no N3 patients. We allow N1 patients, but they have to be N positive. But all patients must be stage 3 and 4. All patients will have baseline functional assessments, so they are required to meet with a speech and language pathologist. They are required to have a baseline modified Barron swallow, and they are required to have baseline patient-reported outcomes, and we'll talk about that next. But most importantly, they have to be P16 positive, and they have to have tumors that arise in a very particular area. So you can't just have like a soft palate tumor, or this really cool tumor you'd like to take off the back of the oropharynx because it's easy to get. Those tumors have unpredictable regional lymphatic metastatic patterns. And so we've chosen very unilateral lesions that have to be away, even with the margin, off of a centimeter from the midline. So very particular patient eligibility. All these patients then simply undergo transoral endoscopic head and neck surgery. They can have robotic resection, they can have laser resection. If you could do a laser or a robot, and you couldn't get access to the robot, that you could do a bovine headlight, provided you get a good margin. And that every single patient must also have a neck dissection. And the heart of this trial, the fundamental question that's being asked is shown here in the intermediate risk group. And I want to kind of direct your attention here and then sort of pan out and talk about what we're doing in this trial, because the design is not very straightforward, really. So after surgery, patients are randomized based on their path. If they had high-risk features, such as positive margins, extracapsular spread that was greater than 1 millimeter outside the node, or more than 4 nodes, 5 or greater nodes, those patients went directly, there's some bad biology with those tumors, and they went directly to post-op concurrent. This group got triple modality therapy, which is what was really such a sticking point for our colleagues initially when we started operating this disease. Let's avoid triple modality therapy because we'll have more toxicity long term. Look at the MAC tape here. Right? So, on the other hand, if you had patients that we thought were N positive but ended up being very low volume N1 or N0, these patients are observed, right? So we've winnowed out the extremes, and we're focusing on this very large group of intermediate risk that are defined here. A little bit of ECS. We're studying not doing chemotherapy for patients with ECS in the very first time since the Bernier and Cooper studies. Patients with lymphovascular and perineural invasion, few nodes, but less than 4, and patients with close margin. We'll talk about what close is a little bit later. In this study, our standard approach, which is the control arm of 60 gray post-op delivered in 30 fractions, over 6 weeks is compared in the experimental arm to a de-intensified postoperative radiation dose of 10 gray, which is radiation delivered over 5 weeks. To do that study and to show that the 2-year progression-free survival for these two groups is the same, i.e. this is a non-inferiority design, we need 377 patients. This is our primary endpoint to look at progression-free survival. So any progression, even distant, would count as an event. But we'll also have a lot of secondary outcomes, looking at local regional occurrence, functional outcomes, and a variety of other things, including some scientific endpoints in the study. So I went through that kind of ad nauseum, but I'll pause if there are any questions. The statistics are kind of interesting. Basically, we hope that in both of those arms, again, the experimental arms right in the middle, the intermediate risk, we anticipate that the overall progression-free survival in each will be 85, and there's very rigorous stopping rules built into the study in case we see something in excess. So very early on in that meeting in Washington in 2011, the big question was, we don't trust you surgeons that you're doing the same thing, right? Everybody's got their own way, and we, as a community, have to come up with some standards so that surgery in Palo Alto is the same as surgery in Philadelphia and is the same as surgery in Houston, right? And I read about this before that meeting and learned some really cool stuff. Did you know for the RTOG, whether you're Quinn Lee or somebody in the little small town like where I grew up who might be running a little radiation therapy center out in the middle of nowhere, they all, every couple of years, have to radiate a phantom. WashU runs this, and they send this thing out through the Mallinckrodt Center, and they get this thing, and they have to design, they're told the tumors in here, and they have to radiate this phantom, and how well they radiate is picked up by all these different sensors, which are measured, and then they get like a pass or a fail. This is how the radiation oncologists credential themselves to do good quality treatment. How are you going to do that for surgeons? I mean, we get DB to operate on a phantom? I mean, he's good, but I don't know if he's that good. So we had to come up with a way to do this, and so one of the ways we did this is to basically standardize how we credential. And it's pretty amazing that people agree to do this. But this is the process. So you have to be part of ECOG or the RTOG, now NRG. You have to get that trial approved through your IRB. And then after you get our IRB approval, you send a letter to the CTSU, which is part of the National Cancer Institute, and they send you back a questionnaire, and they say, please send us 10 cases. I want to see 10 cases of your robotic experience or 10 cases of your laser cases. And I don't want just your operative notes. I want to see paired op notes and path reports, and then a group of your peers, blinded to you, will review your outcomes. And based on your performance and your outcomes and the consistency that we see dictated in those reports, you will be then allowed to participate in this trial. So anybody that actually participates in 3311 actually had to jump through these rather substantial hoops. This is the group of surgeons that is working on this. Most of them are transoral endoscopic surgeons. Eric Sturgis is not, Drew Ridge is not. But we all met, and we have reviewed. This was kind of painful. We met basically monthly for more than a year, and we reviewed about, I think now we're up to 75 or 76 surgeons, and it was awkward. I mean, there were some very prominent people who we said, Len, do you know you sent us like a composite resection? That's not a robotic case. We had a couple of awkward moments where people were reminded that we're taking this very seriously. We have a fiducial responsibility to our colleagues in the multidisciplinary team to look at this. And so we met very frequently, and now up to this point, and I confirmed this with ECOG last week, we've credentialed 66 surgeons. We now have 3 pending, and we're sort of off to the races. Before I give you the update on the trial, I want to talk a little bit about a really mission critical thing. And as kind of, I'm a mid-career guy, and I've seen enough to not be too demoralized, but I've also seen enough to not really be surprised. It really surprises me how little data we have about surgical margins. It's kind of shocking, right? And I know Vasu and others, they've looked at that here with history. And how we take margins is so random and also really not standardized. And it's really a bad thing for our patients. Do you just send the whole thing? Do you take it out with a laser and piecemeal and just send the slivers? And if we've got piecemeal laser excisions and supposedly on-block robotic resections, how in the world are we going to compare all those things? So we actually worked with, we had an RTNG and an ECOG path team, and Diana will be here in May. Jennifer, wherever you are, thank you for inviting her. She's going to come out and talk about sinonasal cancer and pathology. But these two helped Dr. Ferris and I come up with a very regimented way of at least classifying all the variability among the surgeons in the study. And I think I'm really interested in this outcome. And yes, sir.
Before your big reveal, I just gotta take it back to your protocol before your big reveal of the data.
Yeah, it's one slide. It's a very
okay,
sorry.
Yeah, but I mean, for me, not following this literature obviously too much, and for residents maybe. I mean, just a few years ago, ECS and PNI, peritoneal invasion, I thought were equivalent in terms of badness, but now you've subsetted them. PNI was intermediate, and ECS had two subsets too. We could just give us the update on those. It's just that it's that different, huh?
So perineural lymphovascular invasion are actually being studied as part of a risk of intermediate risk in the RTG 920, and there wasn't overwhelming prospective data to implicate those patients as really bad actors. The Bernier and Cooper papers, published in 2004, they weren't really part of it. It was really ECS and positive margins. So we kept ECS, but what is huge about this study is that there are actually going to be some patients who have less than a millimeter of EC or ECS that are not going to get cysts, which is actually a huge leap forward. And I think a lot of us who do this all the time, we really wonder about whether or not it's needed. And so that's a big leap forward in terms of where we'll administer the adjuvant therapy. And it's a big change. So we have also stipulated to those surgeons, not only are the pathologists going to be looking very carefully, we have said you must do this. And if this wasn't done in the credentialing step, then the surgeons weren't credentialed, which is, you'd be surprised. I mean, some people had that was some interesting conversations. But we wanted to see for every section, if they're not en bloc, we wanted to see 4 quadrants superficially, mucosally, anterior, posterior, medial, lateral. We wanted to see at least 1 deep, preferably more than that. I mean, we've never done that before. How embarrassing if we've never done that before. I mean, that's pretty simple. 4 quadrants and deep. But we're really standardizing that. And here's the other leap forward that's very different. We're actually stipulating that 3 millimeters is going to be an adequate margin. Of course, everyone knows it's 5, right? Well, actually, wait a minute. We don't really have any data ever to implicate 5 millimeters as a clear margin outside of the world time. And even that data is from the early 80s. So this is a big step forward, and this study is studying HPV-positive disease, which hopefully will do well. But we have agreed with our colleagues in RADOC and MEDOC that this is a reasonable thing to study based on the previous retrospective single institutional experiences that I described. So one of the things that excites me about this study and this whole movement, if you will, within our specialty, again, it's not the technology, although, with my various devices on, that I mentioned earlier, I love technology. What's cool about this is the reason why we can do this is we took something that when I was a med student and resident, I was told you should never do. Don't ever operate on a tonsil cancer. The internal carotid's there, and the experience in France, I think, motivated a lot of us to tackle this. But we realized that this is just as, a transoral resection or a radical tonsillectomy is just the same as any other procedure if you know the anatomy. But this study, and that's how this launched, or at least one of Tours, I think, launched around this idea of the radical tonsillectomy. But now that we have had the opportunity to study this, we're really going to start to ask some really interesting questions about that surgery. You see this beautiful cadaveric photo here with the medial pterygoid there, the parapharyngeal space fat there. And somewhere buried underneath that is the constrictor. I mean, how thick do you think a constrictor muscle is?
3 millimeters.
Oh, less than 3 millimeters, but yes. We don't actually even know that, right? So anytime we take any constrictor muscle as a deep margin, maybe it's only 1 millimeter, maybe it's 3, is every resection going to have a close margin for the tonsil? And so one of the things we've done based on some interesting work in Korea that actually compared attachments of tonsil cancers based on whether there was no invasion, superficial attachment, invasion into but not through, and then final penetration of the SCM. Our pathologists in this study are actually looking at all these different types of tumor invasion so that we can actually learn a little bit about how this disease invades and how we as surgeons study it. And so that's going to be, I think, another really interesting endpoint for the study. And the pathologists are required to comment on that. Finally, before I give you the update, I'm dragging this out forever. We're going to look at neck dissection outcomes. For the first time, we're going to look at the impact of neck dissection for these patients is not as slight and not as minimal as we think. And this is a really exciting part of the study. We're going to have prospective PROs as well as modified barium swallows in the way that the surgeons had to show that they could have consistent surgical techniques. For Jan Lewin and Kate Hutchison, they had to sort of, twist some arms to get speech language pathologists from around the country to agree on something like, well, a modified barium has to have a minimum of, I think, 24 frames per second. Jan wanted 30. But this has also been standardized for this for the first time. And there's Jan there. So the final point that I want to talk about is stopping orders. Patients can die from this surgery. We're still very early on in our learning curve. Patients have died from bleeding from this, right? We have a very strict policy. If the severe bleeding rate, not death, but if more than 10% of these patients have to go back to the OR, the study's closed, right? And the surgeons all agreed. We all agreed to that before we launched. If there are a high rate of positive margins based on individual surgeons or centers, that center or surgeon will be furloughed from the study and will no longer be allowed to accrue. We take surgical quality very seriously. So here's our trial. You remember the whole design. It's really all about 50 gray versus 60 gray post-op in the intermediate risk group. And we're more than halfway through the study. I just wanted to remind everyone who did the first patient here at Stanford in January of 2014. We're now up to almost 200 patients done by 66 surgeons in 45 different centers. I need to step it up because Bob Ferris is lapping me and it's kind of embarrassing. But we can talk about why that is a little bit later. Here are the number of patients accrued from across different centers. A very large number of these patients have actually just been accrued by a single individual. Several patients, several surgeons have only put one patient on the trial. This is really a quality issue for us. This is an informal report. I have not seen this from ECOG, and these things are very carefully discussed and managed at the cooperative group level. But we all have heard that there have been no deaths on study. We've not had a death from hemorrhage. We've had 4 bleeds. I understood 2 of them went back to the OR. Interestingly, both of those bleeds happened by a surgeon who was not routinely ligating the lingual and the facial artery. For reasons that go beyond the scope of this discussion, we all now routinely ligate the lingual and the facial as part of the neck dissection, and the bleed rates have gone down dramatically. And I did hear recently that there's been a single recurrence, but I think we're about almost 2 years into the study, and I'm very encouraged by this these early results. It's a very complex trial design, and part of our success will be facilitated by almost 60% of the patients going into this arm. We have too many high-risk patients, too many positive margins. The study could become unbalanced, and we'd actually have to go to an even higher number. We're going to continue to watch that, and the team at the ECOG is working very closely. Why is this study so important? Well, we're not the only ones, we as the surgeons, aren't the only ones thinking about de-intensification. Su Yang, who's the PI just up the road at UC, is actually studying de-escalation of HPV positive tumors using a reduced dose of radiation therapy in what's called NRG head and neck 002. Those of you on the head and neck service, you've probably heard us talking about this study. This is very interesting. Basically, our post-op dose is going to be in the range of what the therapeutic dose is for patients getting radiation, right? So I think it's going to be a very interesting time because we're going to have these two studies looking at the same population, and in probably 2 or 3 years, we're going to have a surgical de-escalation trial and a radon, a medon de-escalation trial as well to compare. The great thing is we're actually studying these patients, and surgeons are sort of off the bench and onto the field and contributing. So with that, it's 7 o'clock, a few minutes before, and happy to continue, or perhaps stop here. Yes, sir.
Yeah, a few minutes, right? So beyond, the 25% increased response rate to HPV positive ones, is there anything more known about that? Like, there's more responses to radiation there. Is there something on the cellular or molecular level that's known? The P16 positive, is there something that makes it more susceptible or weaker? Or what is it? Is there something known?
So we all hypothesize that the HPV positive tumors have a lot less genetic heterogeneity, and there's a lot less genomic instability. And there's some good data now that shows if you do sort of targeted sequencing of at-risk genes for all cancers, so from VEGF to EGFR to BRAF, I mean things that we don't even think are associated with head and neck cancer, and you profile HPV positive cancers and you profile HPV negative, the only mutation we consistently see in the HPV positive group is actually PIK3A, the alpha 110. For HPV positives, it's P53, multiple mutations over here. And so those tumors are probably less responsive to radiation. I think that makes the case that we should actually be doing more surgery for the HPV negative disease, regardless of where they're from, but that's for another day. Hey, Ann.
Given our talk last week,
Yes.
cost, more or less, same for those patients?
Yeah, that's a great question. So I decided not to show you guys the next generation because I don't think there's enough time. But how do you have that talk about a $2 million robot after this day, where the Supreme Court upholds the Affordable Care Act? And I think it's a huge question, right? And I think that the radiation oncologists are studying costs of treatment. I think we need to be studying costs of treatment. I actually did a very small pilot study in Houston. I'm going to show you just some preliminary results about. I believe that although the robot is expensive, I think it has a diminished footprint of treatment, and patients can go through appropriately selected patients cost less when they're treated with upfront surgery, and adjuvant therapy is rationally delivered based on their path forward, right? Briefly, the davinci costs about $2 million, but guess what? So does a linear accelerator, and IMRT maybe more. What I did is I looked at 50 patients in Houston, 25 that I operated on, and 25 that were treated with radiation therapy alone. And it's interesting, this is a very controversial subject because in 11 and 12, we kind of didn't want to talk about costs, and I guess we'll have to black this out of the thing, but we just want to talk about costs and charges. But now, with bundles starting in orthopedic surgery in January, we better start thinking about costs, because we're only going to get paid a certain amount. And so if surgery is cheaper, we need to know that. If surgery is more expensive, we also need to know that. And so what we did is I stage matched patients that had surgery versus those patients who had exact same stage, HPV match, who had radiation. and we found some interesting things. So if you look here, in terms of average charges and average cost, surgery was actually a little bit cheaper. And for reasons that extend beyond the scope of this discussion, surgeons don't get paid more or less than radiation oncologists. Radiation is not probably that much more expensive than a 5-day hospitalization. The big difference between cost here is that with surgery, everything happens up front, and a few patients also need radiation, and a few patients who had tours also need radiation and chemo. But more consistently in the group with this relatively early stage disease that got treated with chemoradiation, they were coming in for IV hydration, and they would be doing fine, and then they would have a stay, and then their costs would shoot up. And so I think just in this very small, very early study that Mike Kupferman and Carol Lewis are finishing, we saw that for the right patients, we can maybe save money actually with these very expensive. We'll see. All right, thanks very much for coming, everybody. Have a good night.